welcome all of you. At this point, I want to hand over to the moderator of today's section, which is Dr. Opadola, a senior registrar in the Department of Anesthesia, Obafemi Awolowo University Teaching Hospital. Ma, you are welcome, ma.
Thank you, sir. Good evening. I am Dr. Opadola from the Department of Anesthesia. I want to welcome everybody on board, and I want to appreciate the NSA Executive and the Board of Trustees for the privilege given to the residents to learn and to improve in our academic performance. This evening, Dr. Aliyu Bashir Adamu will be leading us on the discussion on the topic capnography principles and the principles of capnography and the clinical application. So you have about 35 minutes for your presentation, after which questions and the contribution will be entertained. I want us to listen, and can drop our questions and contribution comments in the chat box, or we can signify at the end of the presentation by hand raising. Thank you. Dr. Aliyu, you have the floor.
Yes, okay. So thank you very much. Good evening, everyone. My name is Aliyu Bashir Adamu, registrar from Anesthesia and Intensive Care Department, Abubakar Tafawa Balewa University Teaching Hospital, Bauchi. I'm going to lead us on discussion on capnography principle and its clinical application. This will be the outline we'll follow through. So introduction, the capno is a derived word from a Greek word which means smoke. So capnos means smoke in Greek word. So capnography as an act of measuring the presence of that carbon dioxide within the blood, it helps us in detecting the function of many organs in the body, not only the pulmonary system. Number one, it can give us the idea of metabolic processes that occur within the tissue which generate the carbon dioxide. And then secondly, it can give us an idea that the heart is really pumping blood containing that carbon dioxide into the lung, which the lung now will subsequently excrete in our exhale air, which can be detected by our device that we use in analyzing the capnography. So it has a lot of principles, not only in monitoring the pulmonary system, but also the cardiovascular system and also metabolism occurring in the body. So these are some terms that are worthy of note. Capnometry, this is a measurement of carbon dioxide in a gas mixture, is capnometry, while capnometer is that device that performs such measurement and displays the reading in numerical form. While capnography is the recording of the carbon dioxide concentration versus time. So the normal thing that we visualize on the screen, the act of doing that thing is capnography, while capnogram is the graphical representation. So the waveform that we see appearing and disappearing based on the pattern of the breathing of the patient and other things is the capnogram. While capnograph is that instrument that can give us the waveform display in addition to measuring the carbon dioxide that it can do. So capnograph is an instrument that gives both the waveform, digital data of the carbon dioxide analysis. So we have delay time. This delay time is also known as transit time or response time. Is the time that is needed to achieve at least 10% step in the change in the reading at the gas monitor. So when the gas monitor has started detecting the presence of the gas, the time that is required to achieve a 10% step in the reading of the analyzed sample is called delay time. While rise time is the time required for the change to move from 10% up to the 90% of the total change that we can have within the gas sampling. While the total system response time is what incorporate both the delay time and the rise time. This we will talk about it more when we come to say more about the instrument used in measuring capnography. So historical note, it is worthy to note that capnography has been incorporated by the ASA as a standard monitoring for any anesthetic or sedation technique that will occur. By 1985, that's when the SA adopted capnography as a standard monitoring. While in 1943, that was the first time that the principle of capnography was devised based on the absorption of infrared light by Lopt and Co. And in 1970, capnography was first studied clinically by Smallholt and Callender in humans and has since been researched extensively. Nowadays, even in animal studies and veterinary medicine, capnography has valuable means. So this is a normal capnogram. So as we can see, the waveform, it is plotting the carbon dioxide concentration, that's the partial pressure against time. So it has 4 phases usually. Phase 1, which is the baseline. Then the phase 2, which is the expiratory upstroke. This expiratory upstroke happened because initially the volume of gas within the dead space is the one that is excreted initially, and that contains no to minimal amount of carbon dioxide. Then it will now go to the phase 3, which is the plateau phase. This one represents the emptying of the alveolar gases, and the alveolar gases are usually rich in carbon dioxide because extent has already taken place at the alveolar capillary membrane. Then the phase 4 is the inspiratory downstroke. As the patient starts to inhale, the oxygen-rich gas that is being inhaled by the person now lead to decrease in the concentration of the carbon dioxide, which is detected by the machine, and then there will be a downstroke. Then it will now go to the baseline and the cycle continue like that. So we have some angles. We have alpha angle and beta angle. The alpha angle is between the phase 2 and the phase 3. This one is usually about 110 degrees. But in some circumstances, we may have problem with this alpha angle. For example, if the rise of the plateau phase, that's the phase 3, is so steep that, for example, in cases of bronchospasm or lower airway obstruction, that will increase the alpha angle, which is make it greater than 110 degrees. While the beta angle is the angle between the phase 3 and the phase 4. So when we have a slow fall in the phase 4, meaning if the phase 4 is not falling steeply at a time, meaning there is slow response to the falling of the phase 4 response, then the beta angle can be increased. And beta angle is usually about 90 degrees. So if it increases, it indicates that there is some level of rebreathing that is occurring within the system, either due to incompetent expiratory valve or even when the fresh gas flow is not enough, for example, when we are using a Mapleson breathing system. So this is the normal capnograph that we usually use, which is the time capnograph, which plot partial pressure of carbon dioxide against the inspiratory and expiratory time. So there is another parameter, there is another way a capnogram can be represented, which is known as the volume capnography. In this volume capnography, the partial pressure of the carbon dioxide is plotted against the volume within the lungs. So our tidal volume, which includes both the dead space and the alveolar tidal volume, is plotted on the x-axis, while, let me go to the, this is it, while the partial pressure of carbon dioxide is plotted on the y-axis. So in this one, we calculate the things based on the area of the cup. So we have area under the cup, which is represented by this X, the white area within the cup. That will represent the volume of the carbon dioxide that is being exhaled. While the area Y, which is the area above the plateau, it indicates the alveoli dead space within the lungs. While the area Z, which is to the right of the cup, it indicates the anatomical dead space. So we see this particular tracing or this particular plotting will give us more idea about the ventilation perfusion mismatch that can occur within the lung. Because with this one, we can be able to use it to even estimate the cardiac output in an individual, and we can also use it to calculate our shunt fraction that can occur, for example, in cases of pulmonary embolism and other things that lead to shunting within the lungs. So these are some advantages of the volume capnography and then the advantages of the time capnography. The time capnography is the one that we commonly see in our monitor, so it's more familiar, and intubation is not required. While in the volume capnography, intubation is required. It only monitor when the patient is intubated and under mechanical ventilation. And it also gives us more information about the ventilation perfusion status of the lung. So the measurement technique, usually there are a lot of ways that have been used to measure carbon dioxide in the body. However, infrared absorption spectroscopy is the most commonly used clinically method of measurement carbon dioxide, which is incorporated in most of the capnographs we have in our clinical practice. So it is based on the principle that the carbon dioxide absorbs infrared light at a particular wavelength, which is about 4.3 micrometer. So what usually happens is, depending on the concentration of the carbon dioxide that we have within the sample, the infrared light is being shined to the sample, and then there is refraction of the light, which is detected by a photodetector. And when it is detected by that photodetector, a voltage is being generated, and that voltage that is generated, it depends on the amount of light that passes through and reach the photodetector. So if the light is much, the voltage generated will be less, while if the light that reaches the photodetector is high, the voltage generated will be high. And that's how it will now give us the tracing after converting it into an electrical signal that will be transported into the monitor, and then the tracing of the carbon dioxide will appear. So it's almost similar to the Beer-Lambert loop, whereby the concentration of the carbon dioxide, the higher it is, the more there will be attenuation of the light, which will be detected at the photodetector. So other techniques that can be used in monitoring carbon dioxide include mass spectroscopy, Raman scattering, photoacoustic spectrography. However, these techniques, some of them are obsolete. For example, the mass spectroscopy, while the Raman scattering and photoacoustic spectrography are too expensive to be used clinically, so they are restricted to either research or industrial measurement. While this molecular correlation spectrography is another newer technique that has been incorporated in measuring carbon dioxide, whereby a microstream means of measuring carbon dioxide is used. We will see it later on in the course of the discussion. So we have another chemical carbon dioxide analyzer. This one is just like being on the amount we have in the gas sample that reaches it. So the color changes from purple to yellow depending on the amount of carbon dioxide that is being detected in the gas sample. So usually when the carbon dioxide sample is small, it will remain purple, while if the carbon dioxide sample is large, it will become yellow. So this one monitor even a smallest amount of carbon dioxide, for example, the one that can be found within the esophagus. So when using this particular method to detect carbon dioxide, we have to also ensure that we confirm the placement of the endotracheal tube using other technique, because it is not very sensitive for that. So types of capnograph, that's the device that used to analyze it. We have non-diverting or mainstream capnograph. In this non-diverting or mainstream capnograph, the device is incorporated within the breathing system. So it is attached in between the breathing system and the patient, usually after the Y junction of the breathing circuit, and then before the ETT of the patient. So the gas is being analyzed in situ. As the gas is moving from the patient into the breathing circuit, the gas is analyzed. So there is no need of taking sample from the gas that is passing to go and make the analysis as well. However, this one, it analyzes it in situ as the gas is moving. So this is the diagrammatic representation that we can use to see. As you can see, as the gas is just passing through, the infrared analyzer is detecting the gas, and then it's sending the signal to the display monitor, and then it will be displayed in the monitor, and the waveform will appear. So the response time of this one is very sharp, meaning there is no delay in the analysis. So these are some of the advantages of the mainstream analyzer. It has a fast response time, and there is no delay because it does not take any sample. It just directly analyzes the gut sample, and then it has decreased chance of occlusion by either water or secretion, which are usually a problem with the side stream analyzer. And then this one does not require any scavenging system because the gas sampling does not leave the breathing system. So it does not require any scavenging system. And then sample contamination by other fresh gas flow is less likely as in the other type of the technique. Then the disadvantages, we know it can increase dead space within our breathing system, and it will add bulk to the breathing system. And then in case of leaks, disconnection or circuit obstruction can occur, and this will now lead to disappearance of the waveform completely. Then sometimes even thermal burns injury has been reported with the use of this mainstream carbon dioxide analyzer, despite use of multiple layers of which kept the sensor from direct contact with the patient. So another one is the side stream analyzer. This one is otherwise called the diverting monitor. It uses a pump which aspirate the gas from the breathing system, and then the analysis takes place in the analysis chamber. Usually this analyzing chamber is being zeroed using room air and calibrated using gas of known composition. And then the aspiration occur at the rate of 50 to 150 ml per minute through a tube with a small diameter of 1.2 millimeter. The gas that is being removed can either be vented using a scavenging system or returned into the breathing system. So to avoid water or particulate contamination, a lot of technique has been incorporated. For example, use of hydrophobic membrane, special tubing, or incorporation of filter in it. So this is the graphical representation. As we can see, as the gas is moving, some of the gas is being sampled through the sampling tube, and then it's now go to the carbon dioxide detector. The analysis takes place there, and then the information appear on the screen as the waveform. So as we can see, the amount of time required to aspirate the sample and transport it to the sampling chamber usually make this to have delay in response as opposed to the other mainstream analyzer. So these are the advantages. Cross-contamination between patients is low. That's more with the mainstream analyzer, and then depending on the technology used, it can be used for analysis of several gases. And then the sampling port can also be used to administer bronchodilator, and then it doesn't add weight. It doesn't add much weight to the breathing system, and it does not add much dead space to the breathing system. Then these are some of the advantages. For example, in case of leak or sampling tube obstruction, which can occur because the sampling tube is usually long, so this can lead to absence of the reading and then failure to see the waveform. Then particulate matter can block the sampling tube, which will now lead to failure to see the waveform. And then the sampling line can be connected to the wrong place. And then if there is leak in the sampling line, air can be added into it, which can give us a abnormal reading. Then scavenging must be employed in case of this, or the gas has to be returned into the breathing system in order to avoid contamination in the body. Then a supply of calibration gas must be made available, as this one needs a standard gas to be calibrated against. So another newer technique that is a modification of the side stream capnography is the microstream capnography. This one works based on the principle of molecular correlation spectroscopy. In this one, instead of shining an infrared light, this one produces a particular infrared emission at which the carbon dioxide absorbed, as we said, is 4.3 micrometer. So it produces infrared emission at exactly that 4.3 micrometers, so that the carbon dioxide can absorb, and then that absorbance will now be detected by the detector and then sent to the monitor where the waveform appear, and then the analysis occur like that. And then the sampling rate is also smaller in this microstream capnography. It occurs at the rate of 50 mils per minute. So this gives it a shorter response time because the diameter of the tube is small, and the gas also flow through a laminar flow, as the flow is not much, so it occurs through laminar flow. So that decreases the response time of the capnography, which make it more efficient and effective than the mainstream capnography. And this one can even be used in awake patient, or it can be used in patients that are not intubated. For example, monitoring those patients that are on patient control analgesia using opioid. So the clinical application of the capnography has a lot of clinical application in both anesthesia, in the theater, or intensive care monitoring of patient. So we can use it as a gold standard method of confirmation of correct endotracheal tube placement, then assessing tracheal tube and tracheostomy potency and position. As we know, any obstruction within the breathing tube, either the tracheostomy or tracheal tube, that will lead to failure of the carbon dioxide to now be exhaled, which will not be detected by our capnography machine. So we can be able to detect obstruction at the earliest point. While if the obstruction is minor, we will see some reduction in the amount of carbon dioxide generated, or we'll see abnormality in the waveform of the carbon dioxide. Then ventilatory management. This one, capnography has lessened our burden, especially in managing patients that are on ventilator. Before, we have to use arterial blood gas analysis to monitor the partial pressure of carbon dioxide within the blood of the patient if we are doing our ventilatory management. However, nowadays with the advent of capnography, we can use it to target a particular partial pressure of carbon dioxide within the body of an individual by either increasing or decreasing our ventilatory settings, and also monitoring of patients that are having raised intracranial pressure, which we need to reduce the partial pressure of carbon dioxide in them, which can help reducing the cerebral blood flow and then managing the ICP in them. So capnography can be used, which now helps us reduce the amount of blood sampling we need to take for carbon dioxide analysis. The estimation of cardiac output, this one can occur if we use the volumetric capnography. So using the volumetric capnography, the Peake's principle can be applied to estimate cardiac output. As we know, the amount of blood flowing through the pulmonary system at any point in time in a normal physiology is equal to the amount of blood that is going through the systemic circulation. So bearing that in mind, and in the absence of any pathology, using our volumetric capnography, we can be able to calculate and estimate cardiac output non-invasively, especially in smaller children, neonate, or patients that are more critically ill, for which invasive procedure cannot be employed. So capnography is very useful for that. Then used during percutaneous tracheostomy. As we know, percutaneous tracheostomy is a life-saving procedure for establishing airway in patients with either upper airway obstruction or those patients that have can intubate, can ventilate scenario in the ICU. So capnography can be used to confirm the correct placement of that percutaneous tracheostomy within the trachea, as carbon dioxide will be exhaled and it will be detected by the machine. Then in diagnosis and prognosis of some clinical condition, example, pulmonary embolism. As you know, during pulmonary embolism, a lot of the blood flow to the lung is being blocked. So if there is blockage, meaning carbon dioxide will not reach the alveolar to be exhaled within the circulation. So we may see a reduction in the amount of the carbon dioxide detected by our capnograph. Then malignant hyperthermia also, as the increase in carbon dioxide, end-tidal carbon dioxide, is one of the earliest features that is seen in patients with malignant hyperthermia. So this can help us in detecting malignant hyperthermia as it is earliest cause. Then anaphylaxis also, as we know, bronchospasm is one of the classical presentation of anaphylaxis patients. So capnographic waveform can be used to detect bronchospasm in such category of patient. And also the patient can be hyperventilating, and that hyperventilation can also be detected with the use of capnograph. Then in cardiopulmonary resuscitation, this one we will see it later on in the presentation. So these are some of the abnormal waveforms that we can see in some condition. As you can see, this is hyperventilation. Usually what occurs is during hyperventilation, the respiratory rate is high in that particular individual. So high respiratory rate meaning large amount of carbon dioxide is being exhaled in the body. So we will see a stepwise gradual reduction in the height of the capnograph. However, the shape of the capnograph will be maintained. Then this one is the opposite of that. That one is hypoventilation, whereby the respiratory rate or the minute ventilation of the patient is low. So there will be a lot of carbon dioxide accumulating within the system of that individual. So that will now give a stepwise increase in the height of the graph of the capnograph. So this is rebreathing. As you can see, normally the baseline should come back to 0 because at the end of inspiration, the gas that is being inhaled has minimal or small amount of carbon dioxide. So usually the baseline returns to 0. So failure of that baseline to come to 0, meaning patient is rebreathing a gas mixture that is containing carbon dioxide. So that can be either due to malfunctioning of the expiratory valve, or the soda lime has been exhausted in cycle system, or if we have insufficient fresh gas flow if we are using the Mapleson breathing system. The lower airway obstruction, this is the classical shark fin appearance. As we can see, the rise of the plateau is very steep, and we can see the alpha angle here, the angle between the phase 2 and phase 3 is increased, which is greater than 110 degrees. So that means there is some lower airway obstruction occurring in the patient. For example, patient that is having bronchospasm. The loss of neuromuscular blockade, we can be able to detect it as the curare cleft. This just signifies that patient is taking a respiratory effort within the normal capnographic tracing, because each capnographic tracing represents a complete respiratory cycle. However, with the loss of the neuromuscular blockade, patient may tend to take a respiratory rate while the machine is given its own ventilatory rate. So that will now appear as a notch in the plateau pace. So that is the loss of neuromuscular blockade. It is otherwise called the curare cleft. Then these are cardiac oscillation. They usually occur in the expiratory pace. That one, sorry, in the inspiratory pace, they just signify the cardiac activity that occur in any patient. So the pulsation of the heart are being transmitted and they appear as oscillation within the capnograph. So for esophageal intubation, usually, as we know, once we inserted the endotracheal tube, correct placement will give a normal capnographic waveform because a lot of carbon dioxide are found within the lung. However, if it is an esophageal intubation, the trace may initially start appearing, although it will be small, then later on it will disappear completely. However, in some circumstances whereby patient took a lot of carbonated drink or carbohydrate diet with a lot of carbon dioxide generated within the stomach, the tracing might even be much more than this one, and then it will later on disappear completely. So it's the later disappearance that usually signify what it is, because it cannot sustain the normal waveform as the carbon dioxide concentration is rapidly decreasing there. Then loss of cardiac output, that one, initially we may have normal capnographic waveform. With the loss of cardiac output, and in case of cardiac arrest, there will be sudden disappearance of the capnographic tracing as the carbon dioxide rich blood is no more being brought to the lung by the heart for excretion and then detection. So the capnographic waveform may appear flat. Another thing that can give us flat capnographic waveform is sudden disconnection or total obstruction within the breathing system. If there is sudden disconnection, the waveform appears flat because it will not detect any carbon dioxide there. And then if there is total obstruction at a point in time, it also appears flat because no carbon dioxide will be detected in it. So this is just a table to show us capnography and capnometry will alter carbon dioxide production, meaning those circumstances that the waveform will appear normal. However, the value of the carbon dioxide detected can either increase or decrease. While this one is a table that shows us alteration as a result of circulatory changes. So whether decrease in cardiac output or other impairment of blood perfusion to the lungs in case of pulmonary shunting and other things like that. While this one occurs due to respiratory problem, whereby it can affect both the waveform value and then the end-tidal carbon dioxide value. So capnography and cardiopulmonary resuscitation. The capnography has already gotten a very important role to play in patients that have cardiac arrest. So it can help us to confirm the patency of the airway in those patients, as usually patients with cardiac arrest have been intubated. So capnography can help us confirm that the tube is rightly in place and the airway of the patient is now patent. And also it can help us monitor the ventilatory rate that we are administering to the patient. As you know, some people may over-vigorously hyperventilate the patient with cardiac arrest, thinking that may help in improving or making the return of circulation more favorable. However, it has its own negative consequences. Then it can also help us determine adequacy of chest compression. As he said that capnographic value less than 15 millimeter of mercury usually signify inadequate chest compression, meaning the chest compression is not delivering enough cardiac output into the lung for the carbon dioxide to be excreted. Then it can also identify if return of spontaneous circulation has occurred, because the capnography present earlier than presence of peripheral pulses. As large cardiac output has been ejected and moved to the lung, there will be a sudden increase in the capnographic waveform that can appear. And then it can also use in prognostication during CPR. And it is said that when there is persistence of the value less than 10 millimeter mercury for more than 20 minutes, it has a poor prognostic value. While those patients that have value greater than 20 millimeter mercury have better chance of return of spontaneous circulation and survival after the cardiopulmonary resuscitation. So in conclusion, the capnograph has a lot of function to play, as it appears when the lungs are being ventilated and disappears when they are not ventilated. So the clinician that is skilled in using capnography and identifying the waveforms of the capnography will use it to determine adequacy of ventilation in a patient, and also presence of metabolic activity within that individual, and also monitor the effectiveness of cardiovascular system function of pumping blood into the lungs with the aid of capnography. So thank you very much. These are the references I consulted. And then thank you.
Thank you, Dr. Aliyu Adamu, for this brilliant presentation. Dr. Aliyu has led us over the past 30 minutes in discussion on capnography. It is highly educative and all-encompassing. Well done. We appreciate your effort in putting this together. He was able to tell us about the terminologies, the principles, and the different types of analyzer used for capnography, and also its clinical application in terms of being a respiratory monitor, cardiovascular monitor, metabolic monitor, and the capnography as an equipment. Thank you very much. Questions are welcome. We can drop our questions on the chat box or indicate by raising our hand for the residents. We want to take the rest from the residents. Questions, we can drop it on the chat box, or we can signify by hand raising so that we can be recognized. Okay, Dr. Azan Tijan, you're recognized. You can unmute and
all right. Thank you very much, Dr. Aliyu, for your presentation. Please, in your slide, I noticed that in some areas we're using CO, that is carbon monoxide. I don't know if the capnogram can also measure carbon monoxide level as well, because in some places in your slide, you were using CO. I don't know whether you wanted to say maybe CO2. And then, please, what is the normal value between, let's say, partial pressure of carbon dioxide and then end-tidal carbon dioxide? Is there any difference between the two? And please, what are the normal values? Thank you. Hello?
Okay, thank you for the, yes, I heard you. So thank you for the comment. Actually, it is CO2 I have written. I don't know, maybe the reader is showing less of the O2 because I make it a subscript. So it's CO2, carbon dioxide. It's not carbon monoxide. So the difference between is it the arterial partial pressure of carbon dioxide and the end tidal carbon dioxide you mean? Sorry, the other question.
Hello,
Okay.
please. I wanted to know whether there is a difference between partial pressure of carbon dioxide and end tidal carbon dioxide, and if there is a difference, why? What makes the difference between the two?
Okay, thank you. Yes, there is difference between the arterial partial pressure of carbon dioxide and the end tidal carbon dioxide. However, the difference is not so significant, just about 5 millimeter of mercury difference between the two. And usually what happens is in a normal lung, usually the alveolar partial pressure of carbon dioxide is low, while the blood that will come from the systemic circulation that is being delivered to the lung via the pulmonary circulation has a partial pressure of carbon dioxide about 45 millimeter of mercury. So that partial pressure of carbon dioxide will be equilibrated along the alveolar capillary membrane, and the equilibrium is just that the amount within the two sides of the alveolar capillary membrane will become equal. So once it becomes equal, the transmission across that gradient will now cease. So usually the manifestation, what appear in the end tidal carbon dioxide is usually the reflectance of the equilibration between the alveolar partial pressure and that within the systemic circulation. So in a normally functioning lung, usually that difference is not so significant, but in the presence of ventilation perfusion mismatch, that's when the difference between the two become really significant. So this is the little I know about it. Maybe other people can add. Thank you.
Thank you, Dr. Aliyu. Please, questions are welcome. We can drop it on the chat box or signify by raising hand. Thank you. Dr. Sonny Sulaiman, you can have the floor.
Yeah. Good. Commenting the presenter for the job well done. He has done justice to the topic presented. However, on his response to the last questions raised, I quite agree with him that yes, the end tidal is usually lower than the arterial partial pressure of CO in the arterial blood. Usually, as he said, is less significant, the value between the two. So in some literatures that I came across, it's even far lower than the difference is not up to 5 millimeter of mercury. Sometimes it can be around only 2 to 3 or even less than 2 millimeter of mercury, the difference between the two. And as we all know that the arterial ABG, that's arterial blood gas analysis, measures the PaCO2 directly from the blood. So the value will be higher than that of the end tidal CO2, that it has to take time from the blood to reach the pulmonary system and then into the expired air before it get analyzed by the capnograph. So that's the little thing I want to add on what you have said. And then I also want to say a little bit about the function of the capnograph in the anaphylactic reaction, as you mentioned, that there is one specific appearance that is called shark fin appearance. So Usually that sharp pain appearance, once you see it, it tells you that yes, likely it could be maybe bronchospasm from an affective reaction as well. So, and then on the adequacy of the cardiac compressions, yes, end-tidal CO2, it tells you how adequate your chest compression in cardiopulmonary resuscitation. So, usually once you see value less than 10, as he said, greater than 20 minutes, it tells you that the chances of surviving that patient is very, very not likely. So it predicts a death on that particular patient. So that's the little I want to add. By Allah, to have learned a lot. Thank you to the NSA family, and thanks to the presenter and the moderator as well. Thank you, everyone.
Thank you, sir. Dr. Aliyu, there is a question on the chat box. If you have to choose one device between capnograph and pulse oximeter, what would be your choice? Defend your choice.
Okay, thank you very much for the question. So as we have highlighted within the presentation, we have seen that the capnography monitor a lot of systems, not only one system. However, our pulse oximetry usually monitor only the percentage saturation of the hemoglobin in the blood, which that percentage saturation can also appear even if the patient is totally hypoxemic or the patient is having a lot of oxygen within the system, but in one way or the other, the hemoglobin is not binding to the oxygen. So that will give us abnormal reading. And the abnormality detected with the pulse oximetry, either reduction in SpO2 or increased SpO2, take time. There is delay between the response and what usually happens to the patient. However, the capnography, the essence of it monitoring the respiratory system at the earliest point of apnea, that capnography will show you, because the waveform will suddenly disappear in that particular patient. And when you are seeing a capnographic trace, it is not only showing you that the carbon dioxide has appeared, meaning the lung are excreting the carbon dioxide. However, it gives you idea that metabolism is occurring in the tissue of this particular individual. So in case of people that you are, one is suspecting maybe decreased tissue perfusion or something, that capnograph will give us idea. If there is adequacy of tissue perfusion, metabolism will take place, carbon dioxide will be generated, and then it will be detected. Then adequacy of cardiovascular function, that one, the effective contractility of the heart, it can also give us, as we know, is the heart that is pumping the blood to the lungs with the carbon dioxide. So if the heart is not pumping enough blood, we can see reduction in the value of the carbon dioxide that is being delivered to the lung, which will affect the capnography reading. So for me, I will choose more of the capnography if I'm asked to choose only one, but all the time having both the two at the same time will be better. But in the event, I think I will choose more of the capnography than the pulse oximetry. Thank you.
Thank you, Dr. Ali, for the answer. I think we should put into consideration the resources that are available in getting all these monitors too, that we have. We determine, that can also determine our choice. Our pulse oximetry too also has its benefits too, as a response time in picking saturation, and it can be used in low resource settings too. However, as you said, when the fund is available, we can actually get the two, as both have their role in anesthesia practice. Thank you. There's another question on the chat box that in a situation that you are to choose between pulse oximeter and capnograph, what will be your choice and why? What is the time lag in side stream capnography? I think you have answered the first one. Second one is, what is the time lag in side stream capnography? Thank you, Dr. Liu.
Okay, so I don't know the exact value of the time lag in side stream capnography. Somebody can help me answer that question. Thank you.
Is anybody responding to that? Hello, is anybody responding to that? Okay, we can all check that up. Thank you. Any other question? Questions are welcome from the registrars. So, presently, there is no question on the chat box and I can't see any hand being raised. I want to leave the floor open to our trainers and our teachers that are on board to join us in contribution and to help correct the errors in the presentation. Thank you, Sir Zama. Our senior colleagues, our trainers on the call, your contribution is welcome, Sir Zamas.
Thank you very much. This is Dr. Dati.
You're welcome, sir.
I like the topic or the debate on between capnography and pulse oximetry. I think it will be fair in future to present on pulse oximetry, and then the debate will be more exciting. So I leave it at that. I'm just suggesting that to complete this, between these two that are very important in anesthesia practice and CPR or capnography, we need to present on pulse oximetry, and that will complete everything. Thank you.
Thank you, sir. There is a response on the chat box here that the time lag is between 1 to 4 seconds. More contributions from our teachers and trainers and our senior colleagues. More contributions are welcome.
I don't know if Professor Levy is on the call. I've seen iPhone. She's been using that. I contacted her. I don't know that she was able to make it. Profma, if you're around, maybe you can say something now. Okay, because I've seen iPhone and she uses that.
Okay, sir.
And I've seen a number of trainers here. See Yusuf Bapa, I've seen Ifanyi, who else? I've seen Irene, but I don't know that it is the Irene from the ICCSN. So any of the trainers around, please, you can unmute and they say something. The essence of this presentation is to continue the mentorship here in terms of teaching. Your comments is highly appreciated here because you've seen it all with experience. Your comments will help guide the residents in their exams and also in practice. Thank you.
Thank you, sir. Okay. There is a question here, Dr. Aliyu, that what are the causes of hyperventilation? And Dr. Aliyu.
Yes, I'm listening.
What are the causes of
Hello, I'm not hearing the question well. Hello?
Hello?
Yes, I did not hear the question.
What are the causes
of what?
Hypoventilation and hyperventilation.
Okay. So for the hyperventilation, that's either increase in the respiratory rate or increase in the minute ventilation. That's all hyperventilation. So we can have iatrogenic one, for example, patient that are ventilated, and if someone accidentally set the respiratory rate at a higher rate, that can hyperventilate the patient. Then a normal individual that is not ventilated, pulmonary diseases, for example, pneumonia, can give you hyperventilation. Pulmonary embolism can also give you hyperventilation. Then pain can give you hyperventilation to sympathetic activation that occur following that. Even patient with cardiac failure, patient with myocardial infarction, a lot of them used to come with a lot of respiratory rate, which will eventually give them hyperventilation. While for hypoventilation, it occurs due to decrease in the minute ventilation. So that can occur, for example, patients that are on sedative medication or any medication that depresses the respiratory center can give you hypoventilation by decreasing the respiratory. For example, patients that are on intravenous opioid, either continuous infusion or what, we can see hypoventilation in this category. No, then patient with Guillain-Barré syndrome also, they may have hypoventilation due to affectation of either the phrenic nerve by the ascending paralysis. Also, patient with poliomyelitis, especially those with bulbar poliomyelitis, can come with hypoventilation. So thank you very much.
Thank you, Dr. Aliyu. Let's take the last question. In a patient who just ingested a carbonated drink, what may be the drawback of using the capnograph to confirm correct placement of endotracheal tube?
Okay, the issue with the carbonated drink within the stomach, that does not give drawback to the capnography for correct detection or correct placement of ET2, because in the correct placement, one need to see at least 3 or 5 normal capnographic tracing. That's when we now really say, yes, this tube is correctly in the right place, because virtually there is no any other place that you can have that sustained production of carbon dioxide or sustained detection of carbon dioxide in the body apart from within the lung. So in patients that take carbonated drink, it means that they have a lot more carbon dioxide within their stomach than people that did not take that carbonated drink. So meaning the first tracing might appear relatively normal, might have a relatively higher value. But later on, if you allow it, it cannot sustain itself because the carbon dioxide is not being generated at the time continuous. So once it gets exhausted, you still come and see your flat capnographic tracing. So it actually did not give a drawback per se, but it can mislead in the first instance, yes, but it cannot give a drawback because it cannot give that sustained appearance of the capnographic tracing for 3 to 5 normal tracing. Thank you. People can also add to that.
Thank you, Dr. Aliyu. In the incidence of recent injection of carbonated drinks, I think it's a good point to round up. Thank you, Dr. Ali, for your efforts. Thank you so much. Well done. Dr. Shuaib, over to you, sir.
Thank you very much.
Okay. All right.
Our senior colleagues and our teacher, the professors here, and on behalf of the president of Nigeria Society of Anesthetics and the executive, the board of trustees, I want to appreciate all of you for joining this webinar this night. And if with the permission of the president-elect, we'll be willing to have another one before the residents start their exams upper week. And the topic that will be presented will be post oximetry by a registrar in General Hospital, School of Anesthesia, Lagos, while the moderator will be Dr. Sani Bara, a senior registrar in Department of Anesthesia, ATBU, Bauchi. So at this junction, I will want to hand over to our senior colleagues, the able PRO, Dr. Sele, if there are any other comments, or the president-elect. Thank you very much.
Thank you, Dr. Shaibu. Good evening, everyone. And thank you to all the residents, teachers, and senior colleagues that are on this call. On behalf of the president, the board of trustees, and the executive committee, and the educational committee of NSA, I want to say that we really thank you and appreciate you for being part of this tutorial, of this webinar, and in making sure that we're able to come up with a beautiful presentation like this. I also thank the presenter for his beautiful presentation and all the answers he provided. We just have a few announcements to make. One, in October 16th, we'll be celebrating the World Anesthesia Day. That October 16th is set aside for celebrating World Anesthesia Day. And that same day happens to be the day for marking the World Restart a Heart Day. And so the theme for this year World Anesthesia Day is workforce well-being. And we want to use that opportunity to also mark the World Restart a Heart Day by organizing bystander CPR training at the community level, either in a school, motor parks, markets, or even in our hospital community. So we want to employ you all to please key into this program and help us organize CPR training at your locality. And pictures, video of this can be posted on our NSA platform. We also use this opportunity to employ you all that you should please pay your dues. We all need the dues so that NSA can serve you better. Thank you, and God bless you all.
Thank you very much. Allow me to say one or two words. First of all, this capnography, the presentation of capnography, is very important. I know that Mindtrain is planning to have some trainings on capnography initiative. And there are reasons for that. In cleft surgery, you know, capnography is now very important, if not the gold standard, throughout the surgery. for some reasons. So just stay tuned. I'm sure some of you will be involved in the training. Secondly, I've seen, sorry to take us back, we have Professor Kingsley Toby from Rwanda, and we have Job Otokola and Morai Salah. Please say one or two words of encouragement for the residents. They are doing very well. Thank you. Before we close, please. Kingsley, are you still around? I know you joined late. Unmute and say something.
I'm around. Thank you.
Yeah,
no,
thank
it's
you.
Beautiful. It's good. I'm happy that for this opportunity to just have a very robust discussion. I actually envy the residents. We didn't have all this during our time. So well done, everybody. Well done, President-elect, for the initiative. Thank you.
Thank you, Prof. I'm sure we will engage you more. Morayo.
Good evening, everyone.
Okay, go on. Thank you.
Good evening, everyone.
Good evening, ma.
Good evening, ma.
Well done, President-elect
Thank
and other ESCO, and then the resident that presented. It was a nice presentation. I hope we all learned from it. What I would just advise is just being consistent with your reading and dedication to work. I think with these two things, it will help make it. I'm wishing them all the best in their exam. Thank you.
Thank you, ma.
Thank you. Job, if you are still around, please. Job Otokola, I've seen him, but I don't know if he's still around. Join. I'm sure she wanted to be here, but there were circumstances beyond her control. So she's sent to draw the curtain here. And Shaibu, you said next week, right? Is it next week or in 2 weeks' time? Is it next week?
Yes, sir, Prof. It's next week.
Okay. Okay, so it's pulse oximetry. So I think to do justice to the presentation and the discussion, to have a very good proposed discussion, we should all of us, trainees and trainers, to just look at this topic and come here to have a very good discussion. Thank you very much, and God bless you all. See you next week. Bye.
Thank you, sir. We are grateful.
Thank you, sir. We are grateful, sir.
Thank you, sir.
Thank you, sir.